You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
All right, good morning, everyone. Welcome to Conferences Online Allergy, coming at you from Children's Mercy in Kansas City. This morning, we are privileged to have Dr. Jonathan Bernstein here with us. He is with the Bernstein Allergy Group in Cincinnati, Ohio, and is a professor of medicine in the Department of Internal Medicine and the Division of Allergy and Immunology at the University of Cincinnati. His research interests include the health effects of home and occupational environmental exposures in asthma patients, allergic and non-allergic rhinitis, urticaria and angioedema, including hereditary angioedema, food and drug hypersensitivity, atopic and contact dermatitis, and he has published over 275 peer-reviewed articles on a variety of relevant topics in allergy and clinical immunology, numerous book chapters in addition to editing 4 allergy textbooks. In addition, he's very involved in our local and national professional organizations. He has been the chief editor on the practice parameter on urticaria, and today he will be presenting on chronic urticaria with the best practice for evaluation and treatment. Thank you, Dr. Bernstein, for being here.
My pleasure. Thank you. I just want to, that's an older bio sketch. I'm well over 400 publications now and 5 books, so on different areas of interest and so forth. And I'm also president-elect of the American Academy, so I will be president of the Academy in this upcoming meeting. Today I was asked to talk about chronic urticaria and to really kind of discuss the guidelines and how we would use the guidelines to manage patients with chronic urticaria. These are my some of my relevant conflicts of interests. So we'll describe the burden of chronic spontaneous urticaria, define current day management, and then try to determine current best treatment for CSU. And this is an interesting quote from an article published in 1954 by John Sheldon and a group of actually leading allergists at the time, and talking about the vexing urticaria problem. And they quoted that although urticaria often is a rather transient and trivial illness, they refer to as a trivial illness which scarcely merits serious medical attention, some patients with severe chronic recurrent hives are indeed most uncomfortable and appreciative from whatever help one can give them. So I think that they recognize severe cases, but they really, I think, underestimated the impact, the burden that this condition has on individuals with chronic urticaria. So let's begin with a case study. AB is a 26-year-old female who presents with recurrent hives associated with angioedema that have been persistent for the past 6 months. And during this time, she's been treated by her primary care doctor with short courses of oral corticosteroids that resolved the hives temporarily. She previously had hives in 2013, 2014 that resolved spontaneously after treatment with oral corticosteroids. Her current episode has been much more severe. It involves 95% of her body and includes severe itch that is also sometimes very painful. Her hives are also associated with chills and joint aching, and they've been very disruptive to her sleep, leisure activities, and work. She notes her skin welts when she scratches and when she gets anxious or upset. No prior laboratory testing by her primary care doctor, and she notes the hives are worse a few days before her menstrual cycle and improve but don't completely resolve midway through the cycle. Hold on for 1 second. I think we have an issue of hold on for 1 second. I think this, I need to.
Yes, we can.
Okay, thank you. So this is talk about the classification of urticaria subtypes, and we can see that there's chronic spontaneous urticaria, which is defined as spontaneous appearance of itching, wheals, angioedema, or both, 6 weeks or longer because of known or unknown causes. We certainly see this as the most common form of hives, but a significant percentage of patients can have associated inducible forms of hives, which we refer to as chronic inducible urticaria. Previously, we lumped these patients as physical urticaria, which included symptomatic dermatic graphism, cold urticaria, delayed pressure, solar heat, vibratory. But we now know that there's some of these causes of hives, such as cholinergic, adrenergic, contact, or even aquagenic, are not necessarily inducible, are not necessarily physical, but are more inducible due to other causes, stimuli, for instance, with cholinergic overactivation of the parasympathetic nervous system due to stress, anxiety. As we saw, or body temperature, heat, again, changes in body temperature and so forth. As the body temperature begins to cool from a hot environment, this is what we see in our patients that we just discussed. Urticaria vasculitis is certainly uncommon, but needs to be considered, especially in patients unresponsive to conventional therapies. Now, I want to mention that just in the literature, they kind of talk about patients having persistent hives lasting longer than 24, 48 hours, and then those are the situations where you should start thinking about urticaria vasculitis. However, there are pathology studies that show that patients can have urticaria vasculitis even when their hives are evanescent and lasting less than 24 hours. So it should still be in your differential diagnosis. The triggers, these are triggers and prevalence of CIndU, which I'm not going to go into great detail, but I should say that in our patient, there's evidence that she might have dermatic graphism, at least by history. We should confirm this by doing some type of friction test, whether we use something called a Frick test, which has been developed for dermatic graphism, or a blunt end of an applicator to elicit the response. And she also had evidence of what might be construed as cholinergic urticaria, where there's active or passive body warming that can elicit this response. Typically, the provocation test is exercise ergometry, which most clinical offices don't have. But I think that when it's possible, we should try to reproduce the inducible form of hive when possible. Now, when we see patients with chronic spontaneous urticaria, they typically present between the ages of 20 and 40 years of age, but they can occur at any age group, okay, in children, adolescents, adults, and so forth. So, and again, it's going to depend on the population studied. The duration can last anywhere from, even as 1 year to 10 years, but the mean duration is around 5 years. And when patients have a CIndU component, as we see in our patients, they tend to have a more protracted and severe course of disease. We do know that up to, on average, about 40% of patients with chronic spontaneous urticaria have isolated hives, but another 40% can actually have hives with angioedema. And this is also a form of more severe hives that we should understand that may be more resistant to treatment. And then a subset of patients, up to 20%, may have isolated angioedema. There's a recent CME that we just published in Annals of Allergy that really goes over isolated angioedema, and I encourage you all to read it, as I think it'll provide you some very useful information about these different conditions that can present in this fashion. So in our patient, her prior medical history, she had no underlying chronic health issues, no history of allergies or asthma. There was no relationship to medications, foods, or underlying medical problems. The family history was unremarkable. She was taking cetirizine 10 milligrams a day, famotidine 20 milligrams twice a day, and she was on a prednisone taper beginning at a high dose, which was prescribed at a recent visit to an urgent care center. And she was also using Benadryl every 4 hours, which was causing significant drowsiness. Her social history, she was single, non-smoker, didn't drink. She works as a receptionist, but she notes that her hives were very disruptive to her work and personal life, and they actually interfered with her ability to sleep, exercise, and actually have intimacy with her partner. And I think we can see from clinical trials, this is a study, the ASSURE study, which really looked at the physical discomfort in patients with chronic spontaneous urticaria. And it was quite substantial based on this study. 673 adults with confirmed chronic spontaneous urticaria diagnosis have been symptomatic 3 or more days per week for over 12 months were enrolled across 64 sites in 7 countries. This was a retrospective medical chart and cross-sectional patient-reported data that was collected and analyzed, and they found that 50% of patients had moderate to severe disease activity while even taking medications, and that patients on treatment still had significant symptoms of itching and actually active hives more than 4 days a week. And the burden and impact on quality of life was quite significant, measured by validated quality of life questionnaires, and the most affected domain was physical discomfort. And I think that we see this as what's happening in our patients. We also know that chronic spontaneous urticaria has a direct an effect on indirect costs by increasing absenteeism or even presenteeism, where people are present at work but are not very functionable. And we can see that the number of days per 4-week cycle where there was absenteeism or evidence of presenteeism is much greater in patients with moderate to severe urticaria compared to more mild. But even mild urticaria, there's an element of presenteeism. We see that the healthcare costs associated with urticaria are quite substantial. The hospitalizations are uncommon, but the costs are still high, as outpatient services contribute significantly to total healthcare services. As you can see, this is comparing all cause of healthcare versus urticaria related. You can see it's quite significant. In fact, it actually is comparable to the costs of other major disorders we treat, such as hypertension and diabetes. So in our patient, we looked at this, we try to quantify, and I think it's important, the take-home message is that when you see patients at the baseline, you should do some type of objective assessment for the number of hives. One way of using doing this is using something called the Urticaria Activity Score 7, which quantifies wheals and itching on a scale from 0 to 3 every day over 7 days. The maximum score is 42. So it should, can be done, twice a day, morning and night, over that 7-day period. There are forms, there are now modified forms where you can do it once a day and not have to do it twice a day. So it is a reflective score that typically patients have to record daily. So that makes it difficult from a cross-sectional perspective. But you can actually have a recall test, which is called Urticaria Control Test, and that also touches upon several of the domains, including quality of life, that would tell whether or not a patient is well controlled or not. In this case, patient had a 0 out of 16, so she was not well controlled. And the Urticaria Activity Score, as it goes up in number, that means it's poorly controlled as well. We did try to elicit dermatographism, and it was not reproducible, but it could have been blunted by the fact that she was already on antihistamines. Limited laboratory testing was ordered, including a CBC, sed rate, CRP, and TSH that were all normal. And you can see the extent of involvement in this patient's hives. So there are now several guidelines that have been introduced in the literature, and this is just a few of them. This is the US guideline that was last published in 2014. We are now in the process of generating an updated guideline that will be hopefully forthcoming in the next year or two, which will be based on grade methodology. But the most recent ones are the international guidelines published by the Galen organization, UCARE, which are grade methodology to some extent, and the most recent version was published in Allergy in 2022. So it's important to be familiar with these. These are all open access guidelines, so you should be able to readily access them. But the recommendation for diagnostic workup is illustrated here. It's important to have a differential diagnosis because, as you know, there are many mimickers or masqueraders of chronic urticaria. We certainly want to exclude acute and make sure it is chronic, meaning it's occurring longer than six weeks or longer. And we want to exclude chronic inducible hives before we can establish a diagnosis of chronic spontaneous urticaria, because some patients present with just isolated chronic inducible hives. It's important to check for severe systemic inflammatory disease or other underlying causes, as we did by history in this individual, to get a better assessment of disease activity, which we did in terms of the UAS7, the UCT, which are validated patient-reported outcome measures for disease severity and also for disease control. And then we also have, as we talked about, measurements of quality of life that are also validated. So it's really recommended that the clinician go through this process in order to arrive at a diagnosis of chronic spontaneous urticaria. These are patient-reported outcome tools that I've talked about, the UAS7, which can be administered for 7 days, which looks at severity of itch and severity of hives. We talked about that. There's something called an angioedema activity score, as well as the urticaria activity score, which is a recall of over 4 weeks. And again, that does address the extent of suffering from physical symptoms, extent to which quality of life was affected, how often treatment was not enough to control symptoms, and the overall control of urticaria. So this is what most clinicians use in their clinical practice, or should be using at the minimum. This is just showing how the UAS valid patient-reported outcome measure is scored. It's again a score of 0 to 3. None is none, no itching, no wheals. But if they have mild disease, they're less than 20 wheals per 24 hours, and the itching is present but not annoying or troublesome. And it goes up in terms of intense over 50 wheals per 24 hours with severe pruritus affecting activity. So again, this is used mostly in clinical trials, but could be used in the clinical practice if clinicians were motivated to do so or interested in doing so. These are the quality of life questionnaires, tools that are currently validated and available, which affect, they measure different domains. There is some overlap, but overall they do provide a nice snapshot on quality of life in these patients, and can be used from visit to visit to see if your treatment is actually impacting their overall quality of life. Because it is difficult to do these clinically, I usually just ask how patients feel with respect to these different domains on a scale from 0 to 10 and try to record that. I also try to ask on a, quantify using a visual analog scale on a, what percentage of your body's covered with hives based, if you're 5%, your palm of your hand is 5%, and then get an itch severity score on a 0 to 10 and just ask, well, how severe is the itch? And I do this at visit to visit because you can really get an objective assessment in terms of response to treatment. So I encourage you all to do that when you assess your patients. It is it's important, especially when they don't respond to treatment. We talked about how measuring quality of life can have an impact on physical domains, but it also has an impact on the psychological impact of chronic urticaria. So and this really illustrates the study, how effective management can reduce patient burden. You can see that in patients with the psychological impact, and this is just illustrating sleep problems, physical appearances, limitations, fears, shame, fatigue, and really these questionnaires were able to identify this in patients with urticaria. So it does have a real impact. So it's quite different than what our early teachers and mentors expressed in their article that hives are a trivial disease. And I think it's clear that even mild cases can have some impact. So what are the treatment recommendations for our patient? Well, we certainly don't want her on prednisone, and that's recommended in all guidelines that we can use these for short periods of time, maybe 10 days, 2 weeks, but we don't want to keep people on steroids long-term, as we know they have significant side effects short-term and long-term. So we increased her cetirizine to 20 milligrams twice a day, which is consistent with the 2018 Step 2 treatment of CSU, the international guidelines. But there's consensus with the U.S. guidelines. Both U.S. and international guidelines recommend this. And so this is showing the differences between the European and the international and the U.S. guidelines. And they both recommended Step 1 therapy with monotherapy with second generation antihistamines, and if inadequate control after 2 to 4 weeks, that they would updose, and again, both recommend going up to 4 times the FDA recommended dose of second generation antihistamines. U.S. guidelines differed in that they also recommended you could use another second generation antihistamine, or add an H2 blocker or a leukotriene modifying agent. or a more of a first generation antihistamine to be taken at bedtime. I think that probably the newer guidelines will probably get away from that, but I do actually myself personally use a combination of these. I do actually, in patients who are refractory, will add an H2 antagonist and a leukotriene modifying agents, namely because they're safe generally, they're well tolerated, and they are not expensive. And there is some limited data showing they can be effective, although they do not meet grade methodology, grade expectations, and that's why they were not included in the international guidelines. So I think that this will be addressed in the upcoming guidelines. But it is important just to mention, obviously, when you start someone on a leukotriene receptor antagonist, the caution for the box warnings with intrusive thoughts, anxiety, depression. If they experience that, they should discontinue it, and typically it's reversible. But it is something we do discuss now with the boxed warning. So the patient was followed up. Now she's on 4 times the dose of antihistamines. Her UCT score is now 6. Before it was 0. And her UAS has come down a little bit from 32 to 24, but she's still having daily hives and is very uncomfortable, and it's still interfering with her work, sleep, leisure, and interpersonal activities. Physical exam revealed diffuse hives over 50% of her body. So it was improving, but not completely controlled. So what's the next step? She has refractory symptoms despite maximized dose of non-sedating antihistamines up to 4 times the recommended dose. So is there a consideration to do additional testing? Now, I want to go back to the original testing that was done, which was a CBC with DIF, and it's important you understand why that was done, and a CRP and a TSH. Certainly there's some associations with thyroid, overactive, underactive thyroid, but with respect to CBC, we're really interested in looking at eosinophils and basophils, because we now know that there are hypoeosinophilic and hypobasopenic or basopenic phenotypes that are less responsive to treatment. And similarly, patients with high CRP levels are also less responsive to antihistamines, as even though our patient had a normal CRP, it has been used as a biomarker to actually predict disease outcomes. So when we see these patients, the guidelines actually tell us that we should not be doing any additional testing, but I raised the question, at this juncture where we're thinking about next steps, especially in this patient who complained of a cyclic hypersensitivity component, should we be looking at progesterone hypersensitivity? Should we be looking at a skin biopsy to see if this patient has eosinophils or a mixed infiltrate with eosinophils and neutrophils, which has been associated with chronic autoimmune urticaria? Should we be looking at thyroid autoantibodies or other autoantibodies which have been associated with type 1A autoimmunity and are less responsive to treatment? Should we get a total IgE level if we're considering omalizumab and see whether it's high or low, as patients with lower levels total IgEs tend to have slower, delayed, or no response to omalizumab? And so we look for a chronic urticaria index, which is a basophil activation test that measures as a surrogate marker for antibodies directed towards the high affinity Ig receptor on mast cells and basophils, the Fc epsilon receptor 1 alpha subunit. So these are questions we have to ask, because not all hives are the same, and this is a heterogeneous disease condition, and we might be at the point where we are achieving personalized medicine where we can further phenotype patients and predict response to treatment. This is a study that's been used to actually advocate against ordering tests that was done by our colleagues at the Cleveland Clinic, and they looked at patients who had extensive testing, 356 patients, and they found that only 1 patient benefited from testing, patient with hypothyroidism with normal TSH, with elevated microsomal antibodies that responded to a higher dose of thyroxine, but otherwise these tests did not lead to a change in management with improvement in their clinical hives. So that was the reason for not recommending it, and that's actually is part of our guidelines, both international and US guidelines, not to do extensive testing. Certainly, we should not be doing food testing. We should not be doing testing to allergens by skin or blood unless we suspect a concomitant illness, such as a specific food allergy or a allergic rhinitis or allergic asthma to assess that. And if we do testing, we should do blood, because these patients have hives, and when you do skin testing, it's virtually impossible to interpret the clinical relevance when their skin is already quite eruptive. So here we see a diagram that I kind of borrowed from Jan Lotval, who talked about the different groups of asthma patients that we see. And I think the same can be said now about chronic spontaneous urticaria syndrome, because there's heterogeneous clinical symptoms and presentations. These patients have observable characteristics without direct relationship to disease processes. And when we start breaking down these endotypes, we see that we could say, well, there's antihistamine responsive chronic spontaneous urticaria. There's patients who present with just chronic inducible hives. There's patients who have type 1 autoimmunity, which is defined as antibodies against self-antigens. And some of these patients may have actually autoallergy, where they make IgE to these self-antigens. And this may be the case of progesterone hypersensitivity, because it is a biosimilar. It's an endogenous hormone that patients have been shown to make Ig antibodies towards, or type 2b autoimmunity, where patients make these autoantibodies against high affinity IgE receptors on mast cells and basophils, as well as other effector cells, or is it neutrophilic? And these are patients who don't respond to the kinds of medicines that we normally treat with conventional hives that are mostly eosinophilic lymphocytes with eosinophils. So we should start thinking about these patients maybe at an earlier stage, because the option of going from high-dose antihistamines, which is relatively inexpensive, from going to omalizumab, which is a biologic that's quite expensive, we should think about, is there more of a process that goes into choosing treatments versus just rote, and we follow these guidelines. This is just showing the in vivo autologous serum skin test, which was used originally to look for IgG antibodies, to see if patients make antibodies against Fc epsilon receptor on the mast cells. But it's not a very specific test, and it's, certainly there's a lot of false positives. So it's sort of been put by the wayside. We still use it for academic purposes. It not only measures the antibodies directly against the receptor, the IgG anti-IgG receptors, but it may also measure IgE, IgG anti-IgE, not just the anti-Fc epsilon receptors. Okay, so that's, and also there's also a possibility that it could be measuring a histamine releasing factor as well. So it's not very specific. There's a lot of false positives. So we use more of the serologic testing. Now, this is a study which looked at clinical and laboratory biomarkers in antihistamine responsive and non-responsive patients. And what they found was that patients who are antihistamine responsive tend to have a fewer number of cases associated with angioedema or physical hives versus those who are non-responsive, as we see in our patient who had angioedema and also had an inducible form of hives. They also had a higher likelihood of having autologous serum skin tests, and having higher urticaria activity scores. They were more likely or less likely to be basopenic, and more likely to have higher mean platelet volumes, C-reactive proteins, and so forth. So this is some of the studies that have looked at these biomarkers and trying to establish is there other clinical or other characteristics that differentiate responders and non-responders to medications, or specifically antihistamines. Now, there have also been some reports of basophil and eosinophilic phenotypes. Again, there are basophil responders to anti-Ig stimulation, which we refer to as over 10% or greater histamine release, compared to non-responders. Those who actually are who have higher response, they definitely have longer duration of disease, higher frequency of ED admissions, higher itch severity, and more work loss and poor quality of life. So the basopenic histamine release non-responders were shown to exhibit poor response to omalizumab, independent of anti-Fc epsilon receptor Ig antibodies. So I should say in this case, these are different. The clinical characteristics are quite different than the actual basopenic histamine release non-responders in their response to treatment. There's also eosinophilic phenotypes that have low peripheral blood eosinophils, which also are associated with poor response to omalizumab. And this is a study which looked at these biomarkers, both the clinical as well as the biomarkers, and you can see that in patients, different clinical characteristics, but also their molecular characteristics and their response to antihistamines. See that patients with high D dimers, high IL-6, IL-C5 positive autologous serum skin test, but also basal histamine releasing don't respond well to antihistamines, nor do they respond well to omalizumab. Low IgE levels, high autologous serum skin test or basal histamine releasing activity scores, they do not respond well to omalizumab, where in contrast, these patients may respond better to omalizumab, to cyclosporin, patients with more of these autoantibodies, high D dimers, and so forth. So, there may be these biomarkers may be prognosticators in terms of response to omalizumab versus poor response and a better response to cyclosporin. None of these are currently used in our guidelines to direct treatment. These are things that are discussed in the most recent version of the international guidelines, but they are not currently used to recommend going from one step treatment to the next step treatment. This also illustrates the histology of chronic urticaria, and we showed this is a study we did which showed that patients who had more neutrophils than eosinophils, they were poorly controlled. If they had more lymphocytes, they had better control. Again, if there was a mixed infiltrate, they tend to have equal number of poorly controlled and controlled individuals. And there has been some reports suggesting that mixed infiltrates with eosinophils and neutrophils is consistent with more chronic autoimmune urticaria, which can be found as up to 50% of patients with chronic spontaneous urticaria. So it's something we have to be aware of. I just want to put in a plug for progesterone hypersensitivity, which really presents heterogeneously with different types of skin lesions, and patients can have systemic reactions, but commonly it does occur with severe hives and swelling that begins from any time point from menarche to menopause. Again, it starts at the beginning, about 3 to 10 days prior to menses onset and continues midway through the cycle, or can occur throughout the cycle. It can be very challenging to identify in women who have irregular menstrual cycles. There is progesterone skin testing is unreliable. We do have an immunoassay in our laboratory that we're currently trying to commercialize that has a very good specificity and a positive and negative predictive value. We published this in Annals in 2019 if you're interested, but this is a good immunoassay that we can identify specific IG to progesterone. And I think that one of the interesting things we may be seeing here is not so much that this is an antibody that's causing problems with it may be contributing to these patients with hives, but it may also represent this autoallergy that we're starting to see with other self-antigens, where people make specific IG to self-antigens. It's been reported for thyroid peroxidase, it's been reported for IL-24, and so this is a whole new concept that may be associated with urticaria, not yet established, but something to be thinking about. So what are the treatment recommendations now, comparisons between international and the US guidelines? Well, both the US guidelines really was introduced in 2014 just as omalizumab was being approved for the treatment of chronic urticaria. So there really wasn't a lot of information. So they actually recommended a step 3 treatment to use more sedating antihistamines, more complex antihistamines like doxepin, which is, again, there are position statements out there from the European Union not to use sedating antihistamines for urticaria due to their cognitive and sedating effects. And we also know that these medications can or have been associated with not just cognitive defects, but also Alzheimer's and so forth in some recent studies. But that doesn't mean one can't use them, but one needs to be aware of the side effects and use shared decision making when using them with patients. Some patients will actually not tolerate them very well. So the international guidelines recommend adding on omalizumab as the next line treatment for step 3, and if it's inadequate control within 6 months or earlier, or if the symptoms are intolerable, to advance to cyclosporin, whereas the U.S. guidelines did not differentiate using omalizumab versus cyclosporin or other anti-inflammatory agents, immunosuppressants, or biologics. So they lumped them all together. And again, this was not a great guideline, and there was less information known at the time. But I think that the international guidelines doesn't include these other agents in the algorithm because they didn't meet grade methodology, but they are included in an alternative table which lists all the different treatments that have been used, because it's important clinicians are aware of these alternative agents, especially when omalizumab and cyclosporin are not effective in the treatment of these patients. This is just a study which was looking at, is there a need for alternative novel therapies? And we found in this study that patients who are on different combinations of H1, H2s, leukotriene modifying agents, or even first and second generation antihistamines, only about 38% of patients had complete control. When they were advanced to other therapies like cyclosporin, this was before the advent of omalizumab, 33% were controlled, but a significant percentage of patients still required prednisone. So with the advent of the approval of omalizumab, we see that it has made a significant impact on improving quality of life, reducing hives in patients. Up to 45% of cases, it has been shown to result in complete control of patients with hives, and if you look at partial control, it can be as high as 80 to 85% of patients. There are still issues remaining pertaining to omalizumab, which have been resolved. Previously, it had to be administered in office, but recently, due to safety data during COVID, it's now been approved for self-administration after the first 3 doses are administered safely in a medical facility. It does require having an epinephrine injector due to the risk of anaphylaxis, although we have not really seen that in our patient population, but it is something to be aware of. We still don't know the treatment duration or how to step down, but certainly after 6 months of complete control of hives, it probably is recommended to extend the duration to every 6 weeks, or to reduce the dose from 300 to 150 to see if patients are doing better, and to step down based on shared decision making with the patient. Should we be using biomarkers to predict response so patient selection is more tailored, or should we just blindly start everybody unresponsive to antihistamines on omalizumab? And the other question is, does burden of disease warrant the cost of biologics over time? And I think we can see that there is significant burden of disease, and it does warrant this. And there have been some meta-analysis, some Markov analyses that have looked at this question, and it showed some benefit. So what's the next step? Well, in this case, based on her history and response and treatment, we did start omalizumab every 4 weeks. She was seen 2 months later, was still having hives and intermittent angioedema. Her UCT score was 12 and her UAS7 was 16. And so we have to ask the question, is this enough? Should we fish or cut bait, or should we be trying to do something additional? Should we stop omalizumab and start cyclosporin, or should we continue omalizumab and add cyclosporin? Or, as the most recent guidelines recommend, should we actually updose omalizumab to every 2 weeks, or even increase the dose from 600 milligrams every 2 weeks, which has been reported in case reports, but there really is very little evidence to support these interventions at the present time. So I do want to mention that in these situations, cyclosporin can be very effective in the treatment of patients. It is an immunosuppressant that inhibits multiple cytokines, including production and nuclear factor kappa beta, which is important for producing these cytokines. Toxicity, however, requires monitoring of blood pressure, lipids, renal function on a regular basis. And there are certain patient profiles you probably won't want to start on this: patients who have severe uncontrolled hypertension, people who have some degree of renal impairment or are at high risk, such as diabetes and so forth. You would want to pause and make sure that you're careful in selecting patients. But if you do use this, we do recommend doses of about 200 milligrams a day. We don't really feel the need to increase the dose beyond that. There have been some studies showing that cyclosporin does have an effect on decreasing histamine release in patients, so it may have a direct mast cell effect as well. And we do know that patients with autologous serum skin test or autoantibodies do also have improvement and respond. They're responders. It's reduced. The skin test response is reduced. They have smaller skin test reactions indicating less antibody. And it is recommended for both U.S. and international guidelines. But I think what we're seeing is now these days we're seeing patients who are not responsive to omalizumab or cyclosporin, and so fortunately there are promising drugs that are currently in the pipeline that are looking at alternative mechanisms such as BTK inhibitors, JAK inhibitors, but looking at patients who have cyclic 8 inhibitors. These block cyclic 8 as a receptor that's located on mast cells and basophils. And mast cells and eosinophils. Of course, we're repurposing a lot of drugs like IL-4 receptor blockers. Dupilumab, benralizumab is currently in studies. Tezolizumab, which has been approved for asthma, has just completed a study and will have a readout on their data in the near future. But there were medicines like ligelizumab, which were high affinity anti-IgE antibodies, but in recent studies it showed it was no more effective than omalizumab. And this drug has been discontinued. They're no longer pursuing this therapy. So there is a need for newer therapies. These are some of the clinical trials that are going on that I think are interesting, and they may be doing some of these at your centers, but we'll see where things pan out. There are some nice reviews that have been currently published looking at treatments, not only treatments for chronic spontaneous urticaria, but also the adverse effects of these treatments, which one needs to be aware of before selecting these for patients. And I encourage you to read those. I was going to talk more about some of these specific treatments, but I think due to time, I think we'll stop here. I think in what we certainly know in conclusion is that phenotypes for CSU are heterogeneous. Although these endotypes for CSU are emerging, there's still many others yet to be associated with hives. I think investigation of proteomes and transcriptomes may provide better insights into the pathomechanisms of CSU. Simple hives go into remission after 3 to 5 years. However, CSU with CIndU has a much more protracted clinical course. And certainly the novel therapies used to treat other diseases that target critical cytokines, receptors, and even perhaps other biological pathways appear promising for the treatment of CSU. And I think it's important that we try to follow guidelines in managing patients. The guidelines are living documents. They're constantly changing on a regular basis, so you have to stay up to date. I would objectify patients. I would make sure you use patient-reported outcome measures to assess severity and control on an ongoing basis. I would recommend that you, follow the treatment guidelines, and I think if you do, you'll have really successful outcomes in the management of these patients. Thank you very much.
Thank you, Dr. Bernstein, for that great talk. I'd like to open it up to the audience if anybody has any questions.
That's either a good sign or a bad sign.
I think it's a great sign. I think it was a really wonderful overview, and looking forward to more parameters coming out. And thank you for participating in COLA, and hope to have you continue to stay involved in the future.
It'd be my pleasure, and I wish everyone a good day.
All right, thanks everyone. Have a great Friday.
Bye-bye.